Welcome back. I'm now on location here at Colquitt Regional Medical Center in Moultrie, Georgia, and I'm joined with Dr. Amber Holt, a general surgeon here at the hospital. Thank you for sitting down with me.
Sure, thank you for having me here.
We're talking about cancer awareness, and I know one thing that's huge is breast cancer, and you see a lot of that in your day-to-day treatment.
Yes, I do.
So I want to talk first about who should be concerned about breast cancer.
Sure. Well, really, every woman should have it on their radar. You know, unfortunately, in the United States, 1 in every 7 women will be diagnosed with breast cancer, and so it should be something that every woman thinks about.
Can you tell me what the current recommendations are for breast cancer screening?
Sure. Currently, we're still recommending that every woman at age 40 does receive a screening mammogram, and every year after she should follow with another screening mammogram. If there's something that comes up abnormal along the way, we may change those recommendations in her particular case, but the overall recommendations is at age 40 and every year thereafter. Now, for special cases when a patient's mother or sister or first-degree relative has been diagnosed with breast cancer, we generally start screening sooner in that woman.
Okay, and that first mammogram, is that what y'all consider like a baseline?
It certainly is. We will compare years prior or years after to that first mammogram.
So that's really important to have at that age, the baseline. Okay, and then now if someone, let's say they've not reached the age 40 yet and they feel like they found a lump, let's talk about what they should do.
Absolutely. This is something that I see pretty regularly in my practice. A younger woman will come to me with a complaint of a breast lump. That's something that's new. Important for her to be seen by her physician, and her physician will oftentimes refer her to a surgeon for another exam. The difference with finding a lump is that we're going to do probably a different imaging. In a younger woman, we like to use ultrasound as a baseline imaging study, and especially for palpable masses, ultrasound is a very effective tool. This also would go into self-breast exam. Do we do self-breast exams anymore? It's not part of the real national recommendations at this point in terms of locating a cancer, but it is important for women to know what their breasts feel like normal, so that they can determine what's abnormal or what's new.
Because that is, you know, you may feel some lumps and bumpy areas as you're doing it, but I guess they should notice if they change.
If it changes, that's exactly right. And so from month to month, you should examine at the same time of the month so that it's not affected by your menstrual cycle.
Okay, so just pick that same date and stick with that. Hey, let's say a patient does get a call back and now they've been given the word they have an abnormal mammogram. Let's talk a little bit about that.
Sure, that can be a scary moment, of course, when the radiologist calls you and says, I'm sorry, you've got an abnormal mammogram, we need to see you back for more imaging or you'll need to see your doctor. Most of the time, that's how I meet my patients, is by a referral from either the radiologist or the primary care physician for an abnormal mammogram. Now, that can be a scary time for the patient, of course, but it's I take that as my opportunity to really do a full exam, to get a full family history, to look at all the imaging and decide what do we need to do. And that's something that I can discuss with the patient in my office at that evaluation.
Okay, and then from there you'll decide their course of plan of care, whether they need a biopsy or...
Exactly. Sometimes it's something we can watch with, you know, serial imaging. Sometimes it's things that we need to biopsy. And we can discuss that depending on what it is. Okay. But in terms of the biopsy now, the technology has changed so much that we have so much to offer in terms of minimally invasive breast surgery. It doesn't always require a large incision to get a sample of tissue. We can use ultrasound guidance and vacuum-assisted or suction kind of biopsies. We can use stereotactic with a mammogram biopsy, which really make it simple, easy, under local anesthesia rather than general anesthesia these days, and we've come a long way with the technology.
Okay, so with that advancements in the breast biopsy, like you said, it's more detailed for the patient, needle-guided biopsies, things like that. So does that help the patient get a faster turnaround for results?
Well, I think so. You know, here at Colquitt Regional, we try to get our pathology back within 2 days, and that allows me to really call the patient with hopefully good news, you know, or get them back into my office to quickly plan for the future.
Right, and that is something that you set up, you do that in your office, so they...
In my office at the initial valuation, absolutely.
Have a lot of downtime between getting that news of needing something? And
no, absolutely not, and especially with a breast patient, when I get a call for an abnormal mammogram, I try to work them into the schedule pretty much within that 1 week so that we get them seen quickly.
Great. Okay, we're going to take a quick break. Stay tuned and we'll be right back.